Uganda.
Qualified, professional, and compassionate doctors talking real solutions to real health problems.
We welcome you to yet another interesting episode of the DOCtalk Show, proudly brought to you by Keesiga Productions and sponsored by the Ministry of Health and its partners. I am Dr. Muyanga Andrew Muyanga, your host tonight on the journey into the world of medicine. And this evening we are exploring the topic of postpartum hemorrhage. Did you know that 25% of maternal deaths globally are attributable to postpartum hemorrhage? This comes to a number of approximately 100,000 maternal deaths every year. To our local context, that is Uganda. Did you know that approximately 4 out of every 10 mothers who die after delivery lose their lives because of postpartum hemorrhage? I'll leave you some time to think about that. But as we are thinking, tonight in the house we have a team of specialists from Kawempe National Referral Hospital here to help us to further explore this topic and gain a good understanding of it, and probably at the end of that day, live with preventive measures.
Good evening, our dear viewers. We are very happy to be here today to share with you about postpartum hemorrhage. I'm called Dr. Keesiga-Annette. I'm a consultant obstetrician gynecologist and I work with Kawempe National Referral Hospital. Happy to be here.
Dr. Tomusange Simon. I'm an obstetrician gynecologist from Kawempe National Referral Hospital.
I want to thank you so much for having spared the time this evening to come and share with our fellow Ugandans your hard-earned knowledge. I think it would be important to start from the basics. Dr. Keesiga, if you were having a conversation with my mother, who is hidden deep in Bunyole, what would you explain to her? What would you define PPH as to her?
Thank you so much for that question, Dr. Mark. So as you explained earlier, it's the leading cause of maternal mortality worldwide, and it's even worse for us here in Uganda, being a developing country. So postpartum hemorrhage is defined as excessive bleeding after birth. We expect some degree of bleeding after birth, but when it exceeds a certain level, then we call it postpartum hemorrhage. So what level are we talking about? So if a mother loses more than 500 mils, so we are talking about a tampeko of blood, we say the mother has developed postpartum hemorrhage.
I think as you continue, we need to let the viewers out there to understand that a pregnant mother may have about 6 liters, I think, because non-pregnant is about 4.5, and we account for the increase of about 50%, so to give us about 6 liters. So a mother has about 12 tampekos, if we may put it that way. And you have told us that if a mother loses 1 tampeko or more, then that can be defined as postpartum hemorrhage.
That's very well put. Thank you. So postpartum hemorrhage can be classified as primary or secondary. Now, primary happens if this bleeding is within the first 24 hours after the mother has given birth. However, it can happen even after that. So here we are looking at any time between 24 hours after birth and 6 weeks after delivery. So if there's bleeding that happens within that time, we call it secondary postpartum hemorrhage. And the causes tend to differ for both primary and secondary.
Wow, thank you so much for that piece of info as well. And Dr. Tomusange, I have been seeing you thinking a lot. I would like to inquire about how do you think this issue is common, especially within our local context?
Okay. Yeah, thank you very much for the question. Postpartum hemorrhage or excessive bleeding after delivery is quite common, I would say. Most people talk about 1 to 10% of the deliveries, but I would just of deliveries do get into PPH. The main challenge being, and also you should keep thinking that there must be a certain percentage that goes unaccounted for, because health workers tend to get used to blood loss. So someone sees a certain blood loss and they're like, maybe this is not much, so that they may not tag the patient as PPH, and that goes unaccounted. Or some people really sometimes have challenges of measuring, distinguishing the water that breaks from the baby liquor and the bleeding in its actual self, blood. So I know that a certain percentage of people go unclassified, but it's between 1 to 10%. And bring it into context, in one of the busiest hospital in Africa, which is Kawempe, it is quite very, very, very common. And because it's very common, we have come up with so many measures to make sure that it's, at one point, it was one of the leading causes of death of mothers in Kawempe. Though currently, because of the actions that were taken, it has calmed down a bit, and now something else has taken lead. But I'm just assuring you that it is between 1 to 10% of people who deliver get this complication, and it is quite a very common challenge within the country at all levels of delivery, from health center 3s up to national level.
Yeah. Thank you so much for that information. Certainly, I think from what you have communicated, we still have a lot to do.
Yeah.
But we thank you for your sacrifice and for the service you have offered. I believe you have saved a lot of lives at this point. We would like next, I think, to delve into understanding how postpartum hemorrhage presents generally. What signs or symptoms can a lady out there, or a mother, or a caretaker see and know that this may actually be a postpartum hemorrhage? So, Dr. Keesiga.
Yes, thank you, Dr. Mark. So just before we delve into the signs of PPH, I forgot to mention that, before a mother conceives, they may have actually conditions that predispose them to PPH. Now, a case in point, it's mothers who have anemia, for example, before pregnancy, but also during pregnancy. Now, for such a mother, they will not have to lose 500 for them to develop PPH. So a mother could actually have PPH even when they have lost less blood, depending on probably the pre-existing status. Yeah. So as part of the definition, we say any amount of blood lost that leads to the deterioration of the mother. Yes.
For you people who have studied a lot, I think you are talking of hemodynamic instability in this case. But I will not delve into that at this point. So I think, Dr. Keesiga, you can still take us ahead and start exploring the possible signs and symptoms.
Okay, so the first sign we've talked about is, well, like Dr. Tomusange has said, after a mother has delivered, during the process of delivery, we have this fluid, the fluid that was on the baby that comes out. We do not want that to be part of the blood that is lost. So And after the mother has delivered, you clear that part, and then you change the drapes. So we have drapes that we have that measure how much blood is lost currently. So that drape is put on the patient bed just before delivery of the placenta, so that every drop of blood that is shed thereafter is measured. So for people who don't have drapes, they can use, we have measuring jars in the labor wards. So these jars are there, and this blood can be scooped and measured. So the challenge that we have usually is missing how much blood the patient has lost, and this usually leads to the unaccounted cases that Dr. Tomusange is talking about. So one of the signs actually is how much blood has been lost, but then it has to be measured. It has to be measured very well. So apart from that, usually by the time the patient's hemodynamic stability status changes, patient has lost quite significantly. So some of the signs that we see, symptoms, the patient, usually they become restless, they become sweaty when the vitals begin lowering, and they may become aggressive. So when you have a mother who is, beginning to become uncooperative, you may want to really check how their vitals are, check how much blood they have lost.
You raised the issue of mothers who are uncooperative, and I remember what happens in some settings. I believe this practice over time has actually reduced a lot with health education and all that, the slapping, where someone thinks that a mother is not cooperating, and a few slaps fly here and there, not realizing that actually
the patient is deteriorating.
The patient is going down. I thank you so much for what we have shared. We have a number of signs and symptoms, but we shall come back after this short commercial break. Thank you.
This message is from the Ministry of Health with support from partners.
You are watching the DOCtalk Show.
Tuliko ground, Blascon, paint and win. This year, Blascon paint and win. Tuliko ground, Chicho, buy paint worth 100K. Get a scratch card, SMS the code to 71197. Stand a chance to win instant airtime, 1 million shillings bully day there, or a share of a 3 million shillings jackpot each week. What do you want the brand new podas, tuk-tuks, and so much more? Catch the paint and win action every Monday on Bukede One, NBS, and Sanyuka TV. Blascon, color your world.
The DOCtalk Show.
This message is from the Ministry of Health with support from partners.
I'm called Dr. Biarange Manuel Kayogoza, and I am the Director, Kawempe National Referral Hospital. I'm also a Senior Consultant Obstetrician and Gynecologist. Kawempe National Referral Hospital is a 200-bed capacity hospital that started as a general hospital in 2016 and was designated as a National Referral Hospital in August 2018 by Cabinet. The hospital has 5 mandates. One, we are mandated to do obstetrics and gynecology. Number 2, we are mandated to also handle pediatrics. Number 3, we handle adolescent health. Number 4, we handle HIV/AIDS, concentrating on elimination of mother-child transmission. And lastly, we are a center of excellence for training and research. So a neonate is a baby who is a newly born baby before 28, from 0 to 28 days. But particularly the first 7 days, in fact, the first 24 hours are very crucial for a baby, because that's when most of the complications occur. Kawempe National Referral Hospital has 3 main directorates. The Directorate of Obstetrics and Gynecology, the Directorate of Pediatrics, and then the support staff. and we are one of the busiest in terms of maternal and child health in the country and possibly in Africa. On a daily, we have at least 60 deliveries. That is in 24 hours, but sometimes more. So they range between 60 and 80 deliveries per 24 hours. Out of those 60, almost half are operations, cesarean sections and other operations. For example, mothers who come with ruptured uterus, who come with what we call ectopic pregnancies which are not in the uterus. Those are 100. When you put in those, we handle about 80 mothers per day. At any one time, we have about 150 mothers in the hospital. And at any one time, we have at least 80 babies, neonates, but we also handle other babies who are older. So the hospital is extremely busy, 24/7. We don't have breathing space. Being the only public national referral hospital, our catchment population is the whole country. We get referrals from all over the country, but mainly from the Kampala metropolitan area. As I said, we are a training center. We have partnerships with universities, including Makerere University, where we host the residents. Those are the doctors doing postgraduates in obstetrics and gynecology and also in pediatrics. Our referral mechanism generally is not as streamlined as it should be. And regional referral hospitals refer here, but also district hospitals, which may not be as functional as they should be, refer here. We are a specialized hospital. As you can imagine, we have the expertise, we have the specialists both in pediatrics and obstetrics. There is expertise to handle any kind of complications that may arise in obstetrics and pediatrics. We would be happy to deal with referrals, complicated referrals from our colleagues in the regional referrals and general referrals. So there are all sorts of complications, but the commonest that cause trouble, to be specific, cause mortality, death, and also morbidity, chronic illness, is bleeding. That is what we call postpartum hemorrhage, bleeding, excessive bleeding after birth. But also there is what we call preeclamptic toxemia or eclampsia. This is hypertension specific to pregnancy. But the top main causes of maternal mortality here are eclampsia and then postpartum hemorrhage. So I would encourage our sisters or mothers, first of all, as soon as you discover that you are pregnant, you should go to the nearest health.
Welcome back from that short commercial break. This is the DOCtalk Show, brought to you by Quizmali Productions and proudly sponsored by the Ministry of Health and its partners. I would like to inform you that we are streaming live on YouTube. However, in case you have any question or are inquisitive about something in relation to this topic, please feel free to send that question via our Twitter handle displayed on the screen, or even the number that is displayed. We left off on a point where we were discussing the signs and symptoms of postpartum hemorrhage, and Dr. Keesiga had laid out a number of them, and I think Dr. Tomusange can take us up from that point.
I would just love to add signs like someone feeling weak, completely weak. Someone may actually lose consciousness and faint after delivery. It's not uncommon. Sometimes you can see a pad full of a lot of blood that even scares. It can even happen at a time when the health workers have already declared it all well. They have maybe left with the attendants and they go. Then suddenly they see a lot of blood. They come running. Doctor, the patient has this issue. Then to the health workers, it's one of the main issues, that main indicators that come early is the pulse. The moment the pulse goes high, because we encourage continuous monitoring of vitals after delivery. So the moment someone sees a high pulse in our 100s and above, based on what it was initially, either the patient is having pain or they have lost a lot of blood. But we usually encourage health workers to first suspect the big monster or big culprit, PPH. If you see the pulse is high, even before the BP start dropping, start suspecting PPH, check, have a second look, massage the uterus. And you may be surprised, you massage the uterus and then you get a very huge what? Clot. Huge gush of clot and anything, and then that may be the life-saving step. Wow. So those are the main signs and symptoms.
Let he who has ears hear.
But Dr. Mark, I must emphasize that these signs and symptoms really come as a late presentation. Usually, if we follow the way we diagnose PPH, if the mother has lost so much blood and we intervene timely, we may not have, to see the mother collapsing or, her becoming thirsty and asking for water. Usually by the time the mother gets to that state, it's usually advanced, and we usually want to intervene before these symptoms actually come up. So by the time a mother manifests with these symptoms we talked about, we probably are late on intervening. So intervention should be as quickly as possible.
I think that's another justification for programs such as this.
Yeah.
Currently, the viewer out there knows what to look out for if someone is feeling disease. You talked about the asking for water over and over again. Something is definitely off, and we need to act early. Dr. Keesiga has emphasized the issue of time. What are the common causes of PPH we can think of?
The common causes, like from time immemorial, we have always discussed the 40s. The 40s from school. They are easy to remember, and they're usually directly guiding. Where we are discussing one of the first T's being the tone, like something that changes the tone of the uterus. Like maybe the uterus was so big and now it can't contract anymore. Tone goes with contractility. That every time the uterus is over distended, then it will not be easy for it to contract. That when a baby comes out of this uterus, the way the blood vessels run, it should shrink onto its own self to stop bleeding. So anything that makes it hard for it to contract onto itself, to squeeze the blood vessels that run through to stop bleeding, will cause PPH. And these things are anything that over distends the uterus, like having many babies inside the uterus, 2 and above, having a very big baby, having a lot of water, having a baby with another thing inside the uterus like a fibroid. All those things will affect tone. And then tissue, if tissue is retained, like maybe a placenta is remaining and it didn't come out fully, like some people get retained placenta, that will definitely cause PPH. Some tissues, the placenta comes out and one of the cotyledons is remaining.
What is the placenta?
The placenta is that the placenta is what locally people call it a second child, that when you deliver, there is something else that comes right after that. It is something that the baby feeds from. It is this tissue, huge tissue, that was connecting the baby to the mother, literally feeding the what? Feeding the baby. So some of its tissue is remaining and all of it remaining, or some of its membranes remaining, can produce for the patient.
So you're saying that during delivery, the entire placenta is supposed to
come out and should be examined for completeness.
You talked about tone, and you have also talked about tissue.
Yeah.
Yes, so we are remaining with 2 T's.
So the other 2 T's, actually tone turns out it's the leading cause, of PPH. Accounts for over 80% of the cases. So the other T, one of them is trauma. Now, trauma is could be to the uterus or to the birth canal where the baby passes when they are being born, and to the uterus where the baby usually sits during pregnancy. the trauma could be in terms of tears that can happen during cesarean section, or even rupturing. The uterus can actually give way in the process of giving birth for various reasons. So in lower than that, in the birth canal, we can have tears to the cervix, which we see quite prevalent in Kawempe, and which at times have claimed our mothers, because maybe it was not actually diagnosed when the mother delivered. Mother is bleeding. The tone seems to be very good, as Dr. Tomusange has told us, but some of the mother is still continuing to bleed, but we are not quick enough to detect the tears. So the tears can also be just, sometimes when, especially the first-time mothers, we tend to give them a small cut to enlarge the birth canal, and if that cut is not well repaired, it can actually be the source of bleeding.
The episiotomy?
It's the episiotomy. So away from the tears, the other T is what we call thrombin. There are mothers who are inherently at risk of bleeding. Mothers who have bleeding disorders, take for instance idiopathic thrombocytopenic purpura. Okay, there are hereditary disorders that actually cause bleeding. Then we have also acquired disorders, and the commonest we see being disorders that arise from hypertensive disorders of pregnancy. A mother gets high blood pressure during pregnancy, and this actually causes the body to consume the clotting factors. Hence, when they deliver, she doesn't have enough clotting factors, to stop her from bleeding.
Maybe the other important question worth asking is, who is most at risk of getting BPH?
I would just have to open with a statement that anyone who is conducting any delivery of any mother, you should be ready. Any woman can be at what? At risk. Let's maybe just start by saying that everyone is at what? Everyone is at risk.
So being a
pregnant woman
is a risk factor
in its own, that you should really be ready, because we have had so many surprises. One time you deliver this mother, first time delivery, everything goes as planned, and everyone feels we did it, and in no time some people are saying, hey, PPH, something has gone wrong. So it's usually important or wise to put your high index of suspicion very, very high for every woman who is delivering, especially now that we're in a struggle to make sure that we bring down our mortality rates to below 1 or below 5 in Uganda. That would be a great achievement. But the common ones documented are women who have delivered more than 2 and above children. If you have delivered 3, 4, 5, 6, in some clinical, you even see 11. Yeah. So when you're delivering someone who has delivered 11 children, you don't want to go away from that bed. You want to keep monitoring them. Women who have had this, the diseases tend to go back to people who have had them before. Any woman who tells you, but doctor, last time when I delivered, I bled a lot. You need to tag that one. Because if she has ever happened to her before, chances are high it's going to happen again. People who have very big babies. If you do an ultrasound scan and then they're talking about a 4-point-something kilogram baby, someone is having more than one child, someone already has comorbidities like Dr. Keesiga said, someone already has hypertension, and so on. All those things would make them more at risk of getting this disease, BPH. So those are some of the things that could highlight to you that maybe I need to pay a more closer look at this patient. Maybe they may get into this condition.
Wow. Thank you so much, Dr. Tomusange, for those words. And I think allow us to have a short commercial break, and we shall be right back to continue with this discussion.
This message is from the Ministry of Health with support from partners.
You are watching the Doctor.
Amazina ganje ninyetekwa Seruhanga John Bosco ninduga mu district ya Rukungiri ndio muhanguzi wa miliyoni 18 na Uganda National Rotary nzahangwire urwo mu kuzana star 275 8 nkafuna message erikweka ngo umuhanguzi nashemererwa konka nabaza kugira ngo nebi yabafere sente ziriyo zona bakaziteka ko nazihangwira.
Ugandan National Lottery. Dream, play, win. Participants must be 18 years or older. Play responsibly. The Uganda National Lottery is operated by Ituba Uganda and regulated by the National Lotteries and Gaming Regulatory Board.
You are watching the DOCtalk Show.
This message is from the Ministry of Health with support from partners.
Welcome back from that short commercial break. This is the DOCtalk Show, proudly brought to you by Keesiga Productions. And the topic of discussion tonight is postpartum hemorrhage. We have had a number of discussions, but at this point, Dr. Tomusange, I would like to inquire of you, what steps during childbirth can you possibly take as a medic to prevent postpartum hemorrhage from occurring?
One of the first steps in prevention is let's be ready. Let's have our emergency kit ready for PPH. Anyone who delivers, who has a facility that carries out deliveries, should have their PPH cart, crash cart, ready with everything that is there to help you with the PPH in case it occurs. But the prevention starts with the mother, one, making sure they choose with their feet, they vote with their feet, they deliver from the right place. Because in the right place, which is a hospital or a medical facility, that will make sure your labor is monitored in the right way with a pathograph or with a labor monitoring guide, so that you don't get into prolonged labors that will make your uterus fail to contract, or that will cause your uterus to rupture, or that will cause you obstructed labor and cause you PPH. Then, so monitoring the labor in itself is a step, with the right tools, is a step in itself to prevent PPH. But even before the mother comes in labor, antenatally, if this mother is taking her medicines like dewormers, they are taking iron supplements, they are building blood levels, they are building their hemodynamic well-being. This way, it can help to prevent PPH and its what? And its complications at times. Also, the screenings, if they are done in antenatally, we can be able to highlight some of these coagulation disorders and give them the due attention they need before they reach the point of what? The point of delivery. But during labor, in itself, we pay close attention to, if you have done an episiotomy, make sure that it is not as extensive. It should be appropriate.
Dr. Tomusange,
yes.
What is an episiotomy?
Or if you cut, yes, episiotomy is if you make a cut, like Dr. Keesiga said, if the mother is delivering and you feel like the outlet is not that big for the baby's head or the passenger's head, then you make a slight cut. So whatever you cut, you should be able to repair it so that you stop the what? You stop the bleeding. That can be a preventive method. But also there are medicines that can be given to prevent PPH. Like we know when the baby has come out, the placenta management of that stage, when the baby has come out, we actively manage and say, let us give some medicine like oxytocin to contract the what? The uterus very fast before we lose a lot of blood. That is a PPH preventing step. We can massage the uterus to make sure that it contracts. We can empty the bladder to make sure it doesn't stay full even before the PPH occurs, so that we make sure the woman doesn't bleed so much. Checking the placenta for completeness is a preventive measure in its own, to see that it has all come out and nothing has what? Nothing has remained. And basically those are some of the things that we can do as medics to make sure we prevent these avoidable complications and deaths.
Wonderful. I believe we have a number of viewers out there who had a pen and paper and were jotting down some of the information you have been sharing. But moving on to Dr. Keesiga, for an expectant mother, what other things can they possibly do to prevent such emergencies from occurring?
So as mothers, I'm a mother, so we have a big role to play as far as preventing PPH is concerned. First and foremost, when one conceives, we expect you to go to the hospital to attend antenatal care. So it's during this antenatal care that these mothers are actually, first of all, we talk to the mothers and see if there's any risk in them that puts them at risk for PPH. So we take history, we talk to them, and then when we identify factors, then we note it going forward during antenatal. This is a mother who is at risk of PPH, and everyone who is in charge of that mother knows that she's at risk. Number two, there are factors that predispose these mothers to antenatal. Take, for instance, hookworm infestation, and these are dealt with during antenatal. So during antenatal, they are given dewormers to actually work on the hookworm infestation, but also we give them drugs that prevent malaria.
There is someone out there who is wondering now, Dr. Keesiga is talking about dewormers. How dewormers relate to PPH? And remember, I want to remind you of what Dr. Tomusange talked about when I was talking about issues to do with, was it atony? That if you are anemic, that is, if you do not have enough blood, chances of you experiencing or suffering with uterine atony, that is the inability of the uterus to contract, will increase. And we know that in some forms of worm infestation, actually, you can become anemic. So I hope we have understood that bit, Dr. Keesiga.
Thank you for that addition, Dr. Mark. Yes, also during antenatal, I'm not from the central, but what I have seen being done, I think there are popular practices that mothers are exposed to in the villages, and these include use of herbs. Now, some of these herbs contain substances that actually make labor abnormal, and here it includes labor that is precipitate or labor that may progress too fast, faster than it's supposed to, and this can actually predispose a mother to PPH. So I encourage all expectant mothers, once you go to hospital and you've been given drugs for blood, you've been given drugs to, take care of the worms, to prevent malaria, that is enough. You do not have to, go again into these so many herbs, because we find challenges. Drugs actually can interact, that's one, but also we've seen these drugs causing us issues. So as expectant mothers, let's do our part. Go to hospital, give information, and then take advice. And I think if we do that and also follow through with our visits.
Dr. Keesiga, I want to remind us of something, that we have people who move with clay or mumbo, and after they tell you that if you take this, within a few minutes the baby will be out, and you'll be marching out of the hospital. And I think this still is in line with what you are saying. The herbs are there, but even the mumboas is the word we use locally, I think, are also there. I don't know if you know the ingredients of a mumba, but personally, I do not know.
Dr. Mark, I don't know if all mumbas are the same, because we've had mothers in our labor ward who tell you, I've just taken mumba. I think it's something normal here in the central, but then this mumba seems to have actually complicated this lady's labor. So in my opinion, once you're within the hands of the health workers, I would implore all expectant mothers out there to stick to what the health workers have guided, have prescribed. Do not bring in these other medicines that may actually cause problems.
There is a man I have just remembered, Masaka side, who actually used to make those mumbwas, and he was grabbed, but he was found with a stash of misoprostol. Misoprostol is a drug we usually give to improve on the contractility of the uterus. So he was found with this. Now imagine you have this mumbwa and you are in labor, let me put it that way. But then you maybe have got twice the normal dose a doctor will give you within that mumbwa. And when you go, the doctor, without knowing that you took this thing, may say, okay, let me also prescribe something for this person. That's where complications come from, and we end up blaming the doctor. So I think let each and every one of us play our parts. Are there any other things that a mother should have in mind?
Just be aware of yourself and your medical conditions, and be open to the teens where you go to hospitals. Declare to them, because we know there are diseases that increase your risk of having PPH. So if you declare to the team, it helps them also prepare more aggressively for you. So don't hide your medical conditions. If you are someone with some chronic diseases, you're taking certain medications, you need to declare these medications to the healthcare workers, so that for them they know that maybe you're a cardiac patient, you're taking aspirin, you're taking warfarins, and then you don't tell us. So all these things are going to mess up the delivery process. Yet if you told us earlier, then we'll maybe prepare a lot of blood products preparing for this kind of bleeding, or give you even some other things that may prevent the bleeding.
Well, I cannot add more to what you have said. Let us have a short commercial break, and we shall be right back to discuss the management of postpartum hemorrhage. Thank you.
This message is from the Ministry of Health with support from partners.
You are watching the DOCtalk Show. You are watching the DOCtalk Show.
This message is from the Ministry of Health with support from partners.
Welcome back from that short commercial break. This is the DOCtalk Show. And the topic of discussion this evening is postpartum hemorrhage. In case you have any question, please feel free to send it via the number that is displayed on the screen, or you can even send it via our Twitter handle. It's high time we progressed to the stage of, yes, I have postpartum hemorrhage. Dr. Keesiga, I have just come in. How would you manage me?
So we've moved on to management of PPH using what we call the PPH bundles. And this has markedly improved the outcomes and then reduced the number of mothers that die from PPH. So as opposed to what we were doing previously, now management of PPH using the bundles. So in this approach, we do many interventions within the first 10 to 15 minutes. So within the first 10 to 15 minutes, this mother should have IV lines on both hands, large bore, fluids should be running. You should have given uterotonics. Tomusange talked about them. So we give oxytocin. Then you should have given tranexamic acid. You should have massaged this uterus. So these are interventions done at the same time within the first 10 minutes. So that goes for the first bundle. So in the first bundle, we do the uterine massage. First, we do early recognition using the drapes and measurement of blood, mother's vitals. Then you do the uterine massage. The uterus should be massaged to a consistency of one's forehead. It should be that firm. It should be that hard. And then we give oxytocin. We recommend giving There is the IM that's given during the active management of the third stage of labor, but once PPH has set in, we run 20 international units in 500 mils in 1 liter of normal saline. And can also give misoprostol. Unfortunately, Dr. Mark, the misoprostol which is being used to cause PPH is actually used to manage PPH. So yes, misoprostol is given in a dose of 800 micrograms to actually facilitate contraction of the uterus. And then we talked about the IV fluids. We are talking about running these fluids at a fast rate using the large bore IV lines.
Fluids are what the common people out there know as drip.
Yes, and this patient will have 2 drips on either hand, on both hands, one on one hand and one on the other. Then we also give what we call tranexamic acid. Tranexamic acid is a drug that helps the blood to clot. Okay, so it's given in a dose of 1 gram, and it can be repeated depending on how the PPH is well controlled. If not controlled after 30 minutes, it can actually be repeated, but it can also be repeated within 24 hours if the bleeding recurs. So that is the first bundle. That should be done as fast as possible within the first 10 minutes. So if after all these interventions, the mother is still bleeding, then we examine. Realize during this time, we have not even examined the patient to see if the tears down. So we are doing all these fast. Then, but if bleeding is still bleeding after all these interventions, then we examine the patient. So we are going to examine for the tests that we talked about. And then, depending on what you find, then we escalate the care to the second bundle.
Interesting. Do you think we need another second bundle?
Oh, yes. And I also must say that most of the PPHs resolve after the first bundle. Because remember, we said atony, which is failure of the uterus to contract, accounts for over 80% of the cases. So when we do all these things, both the mechanical, the massage, and then the medical, the drugs we've talked about, the uterus contracts, and then over 80% of the PPH has been resolved. But how about PPH, which is from the tears or the retained tissues? Okay, so depending on what you find when you examine, if you find a tear, for example, during that examination, then if it's a cervical tear, you clamp. And then this is a patient you're going to move to theater and repair. If it's a uterine rupture, God forbid, because these ones have a very high morbidity and mortality, then the patient needs to be rushed to theater in the shortest time possible. And there are different surgeries that are done for a patient who has had uterine rupture. If the problem is the other T, thrombin, the problem is with clotting, then we need to mobilize blood products. But there is also what we call UBT, the tamponade of the uterus. So we introduce a balloon into the uterus at the site where the bleeding is coming from, and then this balloon is filled with water. It basically applies hydrostatic pressure onto the bleeding points, and that can temporarily or even stop the bleeding.
Dr. Tomusange,
Yeah.
In a summarized way, could you possibly enlighten us about the complications of PPH?
When PPH occurs, it can lead to death. And you know death and its complications. When PPH occurs, it can shut down your kidneys through acute kidney injury due to blood loss. When PPH occurs, it can cause, you can have transfusion and the transfusion complications and transfusion reactions. When PPH occurs, we can stitch you multiple times in the private parts or in the vagina, and you get morbidity. You get chronic pelvic pain from the healing of the livers. When PPH occurs, sometimes we can be giving you fluids and we cause fluid overload. You get lung edema, a lot of fluid in the lungs. You end up in ICU because of that. When PPH occurs, sometimes we have to remove the uterus.
Yes.
So this woman has no uterus anymore, because if that's the only thing that's going to save you, we can go in about 10-15 minutes and we get out the uterus, so that you're at least alive, but with no uterus. And that has a long social discussion along it.
It's a lot.
Someone will say, I'm no longer a woman without a uterus. Then another man may want to run away from this woman with no uterus. It's very, very complicated. So
the psychological implications.
The implications of a hysterectomy. Sometimes we stitch up the uterus so many times to stop the bleeding, which may cause scars inside the uterus and subsequently lead to subfertility. So there are quite a number of issues that can come. DIC. Someone keeps dying away at your watch.
DIC, but I will not tell the audience what it is. That is a whole topic.
It's a whole topic in its own.
Is it Sheehan syndrome?
Yeah.
That is a whole other topic. I don't know if you have encountered it in your time.
Because you know when some mothers bleed, in that excessive bleeding, it will interfere with the way messages are sent from the pituitary to the ovaries to let her go into periods. So she may undergo this severe bleed, and then after that she may never see her periods again. And then that will have a lot of other endocrinological consultations and how she can be helped, which is quite very long. So all in all is that prevention of PPH is the way to go, and early recognition and treatment should be our goal.
Dr. Keesiga, kindly give us your parting shots, followed by Dr. Tomusange.
PPH is 100% preventable. So to the mothers, let's attend antenatal care. Let's deliver in the hospital. Let's do away with the traditional medicines if that's possible. To the health workers, early recognition and timely intervention is key if we must prevent and stop deaths that are coming from PPH. If anyone is challenged about how to manage PPH, through Ministry of Health, you can have trainings brought to your hospital and improve the knowledge as far as PPH management is concerned.
My closing remarks would be, one, let's all be vigilant, very vigilant, and when you're managing PPH, be as fast as possible. Okay, you don't need to whisper to the team. It's bring this. Everyone has to run very fast, because every drop matters. To the health workers, don't get used to blood. They say, ako katono. Like every drop does matter. So don't get used to the bleeding. Then don't bite more than you can chew. If you see some patients are not at the level of your facility, feel free to do a timely referral, and always have your network. You can have a network of ambulances. If you don't have an ambulance, you can have phone calls. You can call and then get an ambulance to you. Now Kampala, KLNMS, Kampala Local Maternal Neonatal System has ambulances you can call. So you need to have all these contacts handy if you're a midwife conducting delivery in your small kafunda somewhere, and then have people you can call for help.
I think the experts in the field have spoken, and I cannot add more. But I want to close by saying that every mother who has carried a child for 5 months, 6 months, 7 months, 9 months deserves to experience the joy of seeing their child grow up. Let us support these mothers. We thank you for having tuned in. This has been the DOCtalk Show.
This message is from the Ministry of Health with support from partners.
UBC, inspiring Uganda. In the aftermath of crisis, hope is often found
in the hands of those willing to rebuild. For the youth of Moyo District, this hope comes in the form of skills that last a lifetime.